So in terms of temporary access, there's three main ways that we approach enteral access in terms of actual tubes. So the one that people see very commonly on the floors is the drop-off tube. And this can be either placed from the nose or from the mouth down the esophagus and typically into the stomach, although it can be advanced post-pyloric or under fluoroscopic guidance. At other institutions, they can sometimes do that at the bedside as well. The drop-off tube is nice because it's soft, it's flexible, and in comparison to some of the other tubes, it's not as uncomfortable. But really, its main use is to administer nutrition and medication. So you can't really use it for decompression. In contrast, sometimes people will call a nasogastric tube or like NG tube to use for decompression. Usually what they're referring to is a sump type of tube. So the most common type of sump tube is a Salem sump. It's much more rigid, less comfortable, but not only does it allow you to administer medications and nutrition, but it also allows you to decompress the stomach. So you'll see these commonly on surgical services in patients that have bowel obstruction, post-op, things like that. In contrast to the drop-off tube, they can't really be advanced post-pylorically, typically just placed into the stomach and left there. But when you need decompression, that's the way to go. I think the last kind of temporary enteral access is endoscopically placed tubes. The key thing with the endoscopically placed tube is that the tube is actually threaded out through the instrument channel in the scope. So usually when we place a tube endoscopically, most often it's into the jejunum. Because it has to fit through the scope, it's very long and very, very thin. And as a result, it clogs very easily. So endoscopic tubes really are only used for tube feeds or liquid medications it can be used for. But if you start crushing pills and trying to push them through an endoscopic and J tube or NG tube, it will clog quite quickly. I think one of the common questions that comes up, there's a patient on the floor, it's really hard to place a drop-off. Can GI place a drop-off endoscopic? The challenge with that is we don't place a drop-off really any differently than the primary team. We still put it through the nose and push it down, similar to how a primary team would do at the bedside. The main difference is we can put a scope in the mouth and look at the tube and make sure it's going into the esophagus rather than into the trachea. The problem is taking the scope out, but leaving the tube in place. If you can imagine, the esophagus is a muscular tube. So you have your scope in the esophagus and you have the drop-off in the esophagus and you have this kind of muscular compression around it. And your goal is to remove the scope, but leave the other tube in place. And the problem is that because the esophagus is contracting and it's a small area, the two are kind of stuck together. So as you withdraw the scope, you end up pulling the drop-off out as well. And so it's not something that we typically recommend.
Okay, all my residents ask me, does it matter where the NG tube terminates or the drop-off terminates? Or if it's based on continuous feeds versus bolus feeds?
Yeah, so that's a great question. So I think it does matter with regards to whether it's in the stomach or the small bowel. So obviously the stomach can accommodate a large volume. When you're thinking about bolus feeds, essentially it's like a meal replacement, right? So you're like drinking a large volume of liquid. And so that's fine for the stomach as long as the patient can tolerate that okay. But you typically don't want to do bolus feeds into the small bowel because it's not made to accommodate that large volume. So typically in jejunal feeding, you're thinking about either continuous feed or a cycled feed. The patient can tolerate a cycled rate.